Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about stroke. Stroke is an extremely common medical problem. Across the world, 15 million people develop a stroke every year, and 12.7 million of these people develop stroke because of hypertension. In this country, 795,000 people have a stroke every year. 600,000 of them are new strokes, and 185,000 of them are recurrent stroke. Very serious problem. And the basis, the disease that is associated more than any other diseases with strokes, happen to be hypertension. So when I left last week, I was making certain points which I want to clarify in this segment, having to do with the role of the kidney in the development of hypertension. The bulk of the hypertension that occurs is a result of the kidney. The kidney is the genesis why one has hypertension to begin with, and the kidney is the organ through which one has to pass in order to lower the level of elevated blood pressure in most instances. Not altogether, but in most instances. The gene that is located in the kidney that is responsible for essential hypertension is called G protein receptor kinase type 4, G protein coupled receptor kinase type 4, which I originally proposed the possibility that such a gene existed. It was subsequently discovered, as I mentioned, and published in the proceeding of the American Academy of Sciences in 2002. Now, having said that, in order for you to treat blood pressure, you must be completely familiar with the ethnicity of the individual that you are treating for blood pressure. One thing that is universal when the kidney is functioning properly is the treatment of the blood pressure with hydrochlorothiazide. That's a diuretic. That's universal in everybody, regardless of the person ethnicity, regardless of the person sex. That's it. Now, the second step, however, that's when one needs to put one's thinking hat on, because of two physiological processes that I'm going to explain, which I probably didn't explain well enough last week. Namely, there's one system called the renin-angiotensin converting enzyme inhibitor. That's one system. The second system is a renin-angiotensin converting enzyme receptor blocker. That's the second one. That's a renin-angiotensin aldosterone receptor blocker. That's the second one. The first one produces a series of medication called ACE inhibitors that you have to block the level of renin in order to lower one's blood pressure. However, the key that I wanted to explain last week is that all non-Caucasian individuals, regardless of the tiniest little bit of Negroid ancestry they have in the gene, have low renin. Let me repeat that. All non-Caucasian persons across the world who have normal kidney function have low renin. And all Caucasian persons across the world that has normal kidney function have high renin. That's it. So, therefore then, it is not very smart to prescribe an ACE inhibitor for a non-Caucasian person who has normal kidney function, because there's not enough renin to block, because they genetically have low renin. They were born that way, made by God that way. On the other hand, if the person is Caucasian and their kidney is functioning normally, then you could prescribe an ACE inhibitor for them because they have normal to high renin. You could block the renin. So far, so good. Okay, that's one system. The next system, as I mentioned, is a renin-angiotensin converting enzyme aldosterone blocker. Okay, which means that That system, you need to go all the way to the end of it, to the point of aldosterone is the last step in that system. You have to go all the way to the level of aldosterone, which is the salt retainer. That's the hormone that causes you to retain salt, to block that. That's where the blockers come from. And all these medication called ABS inhibitors, which is basically they will block the entire system all the way through. And ACE will not block the entire system all the way through. It will go to the level of the renin, and that's it. However, when you use an AB, it blocks the entire system from the beginning all the way to aldosterone to prevent aldosterone from holding on to salt, holding on to water, and raise the blood pressure. So therefore then, as long as the kidneys function properly, an AB will work in everyone who has normal kidney function, regardless whether they're men or women, Caucasian or non-Caucasian. But not so for the ACE. That's the point I was trying to make. Maybe I didn't explain myself clearly. ACE has limited value as it relates to blood pressure. ACE is fantastic medication. We use that in the congestive heart failure, blah, blah, blah. We use AB in congestive heart failure as well. So what's the sense of using an ACE and a non-Caucasian person who has high blood pressure and congestive heart failure when an AB will do the same job all the way through? The point I'm making is that this is crucial because, believe it or not, because the ACE are cheaper, the HMOs and the all insurance companies who control the medication in this country, the system is loaded with ACE inhibitors. And yet, ACE inhibitor had limited use in the treatment of blood pressure. Because, let me give you an example. There are a little bit more than 7 billion people in the world. Guess what? 4 billion of them live in Asia, and all these folks are not Caucasian. 1.5 billion lives in Africa, and they're not Caucasian. So 5.5 billion right there. And I have not touched Europe, and I have not spoken about North America. How about that? So you can't force this medication, the ACE inhibitors, on these folks, which is the majority of the world population, because they have low renin. There is not enough renin for them to block. That's the scientific fact. Unless the kidney is starting to malfunction or they have end-stage renal disease, at which point the renin is high in everyone. But guess what? Both the ABs and both the ACE are contraindicated in this setting. Once somebody's kidney begin to malfunction, you can't use an ACE, nor can you use an AB. Why? Because that will cause the BUN to become higher and the potassium to go higher. And that's why ACE and AB are both contraindicated in someone whose kidney is malfunctioning. This stuff is crucial for people to understand. You can't just take a pad and write prescription for folks without knowing. So therefore then, I wanted to clarify that. Since hypertension is the most common disease that is associated with stroke, I wanted to let you go back. I've done many, many shows on hypertension. I've explained that before. I wanted to go back to understand how crucial it is that people get treated properly for their blood pressure so as to prevent them from having stroke, from having heart attack, from having congestive heart failure, and from having kidney failures. Because one of the most common causes of kidney failure is hypertension as well. So if one does not understand this stuff, and you adhere to it on a daily basis, then what's the point? What's the point? Therefore then, I'll go back now that I clarified that, I'll go back now and go over with you to finish the list that I started last week of things that can cause someone to the different risk factor for stroke. As I said, atherosclerotic ischemic stroke, 61%. Lacunar stroke, 20%. Another risk of stroke is hypertension, as I mentioned, diabetes, hyperlipidemia, obesity, metabolic syndrome, hypercoagulable state, primary polycythemia, essential thrombocythemia, kidney failure, sickle cell disease, atrial fibrillation, cancer, tobacco use, Trousseau syndrome, thrombophilia is associated with elevated lipoprotein A, elevated homocysteine, and a whole host of other thrombophilias, low vitamin B12, folic acid deficiency, low protein C, low protein S, nephrotic syndrome, antithrombin 3 level, low antithrombin 3 level, obstructive sleep apnea, taking birth control pill or any estrogenic hormone. If you have thrombophilia, you could stroke, you could clot and stroke because of that. Elevated antiphospholipid antibody, elevated circulating lupus anticoagulant, HIV/AIDS, factor V Leiden mutation, prothrombin gene mutations, hyperviscosity in cases of multiple myeloma. If one's hematocrit, red blood cell, is higher than 40 and one has kidney failure, you could actually stroke because of that. So you got to be very careful when somebody has end-stage renal disease not to raise the hematocrit past 34, 35%. If you do, then you risk of causing hyperviscosity because the underlying vessels that led to the individual having either the stroke or the kidney failure, the vessels are bad, and the vessel cannot withstand the viscosity of too much blood. So therefore, they can stroke just like that. Okay. Now, I think there are a few more that I left out. But let's go back then talk about a symptom of stroke. Now, this is really so long. You have to understand, I have not started to evaluate yet, but this is 2 pages long. And believe me, I will not bore you with all of them. Suffice it to say, the most common abnormality associated with strokes: inability to think, can't talk, can't breathe properly, can't feel things properly, can't taste things properly, you have lack of desire for food, insomnia, you're unhappy, bad mood, no motivation, can't walk properly, stumbling around all over the place, can't move your arm, sometimes you become paralyzed. And the list is quite long, so I'm not going to bore you with 2 pages and reading that to you. Suffice it to say, stroke is not something one will wish on anyone. It's a bad condition. So now that you have idea of some of the symptoms, how do we go about evaluating somebody for stroke? Well, patient will come in. You will take a history if the patient can give it to you. Sometimes they can't. Only the family can give it to you. If they can talk, you could listen to them. You find out underlying medical problem. Are they diabetic? Do they have sickle cell disease? Suffer from hypertension, obesity, and so on and so forth. So you take the history from them. You take a family history, you take a work history, and so on. Then you will carry an examination. And the examination start all the way from the head all the way down to the toe. Very, very important to examine the eye properly, to look inside the eye, to look at the pupil, and so on. Because if somebody's brain is under pressure, the pupil will look a certain way, etc. Then you examine the heart. What are you looking for in the heart? Well, you make sure the rhythm is regular, because if you have atrial fibrillation, as you examine the heart, you could tell. If you're having other type of arrhythmias, you could tell the irregularity in the heart. You may not tell specifically what they are, but you could tell that the heart rhythm is irregular and so on. To do a very strong, thorough neurological evaluation, looking for what we call focality, indicating the weakness of one extremity or another, and so on. Try to see if the patient can walk, very important. Then once you finish your examination, then you're going to begin to do an evaluation. Evaluation includes a complete blood count, complete chemistry profile, complete urine analysis. You do PT-PTT to look at the coagulation profile. And depending on who you're dealing with, you do some evaluation for some thrombophilias, so such as homocysteine level, lipoprotein A level, check the B12 level, check the folic acid level. What's the relevance of that? You have to understand both low B12 and, in particular, low folic acid can cause in particular, low folic acid can cause the homocysteine to go up. So if your homocysteine goes up, that can cause you to stroke as well. Now, you have people who have hereditary disease that cause them to have abnormal homocysteine. These people have a high risk of developing stroke. And of course, if the vitamin B12 is low, then that also predisposes the individual to having a stroke as well. So B12 is very important. Check the serum ferritin to make sure that the person doesn't have severe iron deficiency that can also lead to abnormality of perfusing the brain properly, that can be so anemic that can also predispose somebody to a stroke. Then it is absolutely proper if you ask the patient, if the patient can or the family give you permission to evaluate the patient in this day and age where we're living to make sure they don't have HIV/AIDS. You have to get permission for that. You check the SETI rate very carefully. You do a rheumatoid factor. You do an ANA, because there are a long list of autoimmune inflammatory diseases that can cause somebody to stroke. By doing the SETI rate, right away you know it's elevated, but any inflammation or chronic infection can cause somebody's SETI rate to become elevated. So that's crucial. And then you do an ANA. If the ANA is positive, then you do an ENA that will tell you if the person has some autoimmune diseases that can cause them to stroke. The blood count, the platelet is crucial. If the platelet is elevated, then that raises the red flag, because if you have essential thrombocythemia, that can lead to stroke. If the hematocrit is too high, that raises a red flag, because you could have polycythemia, either primary or secondary. If you have pancytopenia, meaning the white count is high, the platelet is high, and then the red blood cell count is high, that raises the red flag that the person may have, polycythemia vera. Then that leads your evaluation in a certain way. If the white blood cell count, and then let me give you a quick key right there. I said to do a ferritin, okay? If you have pancytopenia, red count is high in the 50s, above 50. White count is high, platelet is high, and you suspect that the person may have polycythemia vera. One of the first things, before you get all these other fancy stuff done, there are a lot of fancy things out there. Take a look at the ferritin. Because if you have polycythemia vera, I'm going to tell you, your ferritin is going to be 0. Let me repeat that. Right there, looking at it, simple. You haven't gotten to the very expensive, fancy stuff yet. But you can have pancytopenia secondary to polycythemia vera with a normal ferritin. That's not going to happen. Why? Because it is the iron that's being used to cause the red blood cell count to be so high. So therefore, in the presence of polycythemia vera, which is a very common thing, and it is highly associated with stroke, by just going through it right there, the ferritin will be 0. So that's your first clue that the pancytopenia cannot be polycythemia vera, because there are associations where both you can have pancytopenia to mild degree, especially the platelet will be very high, and then you could confuse the two between polycythemia vera and essential thrombocythemia. Okay? Because if you do, then you are going to the wrong path. I can sit here and tell you stories that I will not tell you, but I'll give you a hint. It took 5 years, 5 years fighting with the big powers to be, but the big powers to be didn't have the knowledge that I have, thinking that I had misdiagnosed somebody, and they were 100% sure that this particular patient has essential thrombocythemia. They didn't miss the diagnosis. Of course they did, but they were 100%. They even went as far as having a pathologist from a famous hospital in Long Island writing a letter saying the patient has essential thrombocythemia. Then he took the plane and moved to Israel for a year over there, so they couldn't find him when they wanted him because he was in Israel. And he wrote the letter and left. He was completely bogus, okay? And I was looking at the lab results. I was not the one who ordered the ferritin. I was just looking at the lab results. I didn't even know that I was being set up, but I was looking at the lab results. As I'm flipping to the page, I saw pancytopenia, high red cell, high platelet, high white count, low ferritin. Right there, before I even talked to the patient, I made a diagnosis of polycythemia vera. You can't make this up. And it took 5 years, 5 years, with such sick egos. These people refuse to leave me alone, thinking that their patient has essential thrombocythemia, which she didn't. I went on to do all the expensive tests, but I knew that within a few seconds when I look at the result, because the patient has low ferritin. Right there in front of them, they didn't know. And they bothered me like you wouldn't believe. It turns out that I finally got a letter from the patient in question from Hudson Valley Hospital. They used to call it, they changed the name now. 2 pages letter thanking me, congratulating me. She's now being treated at Hudson Valley Hospital via phlebotomy, removing units of blood from her because she has polycythemia vera, which she had all along. 5 years ago, I knew that. Within a few seconds, I hadn't touched the patient. I hadn't taken a history for the patient. I was just going through it. It took 5 years. And then when I got that letter, you have no idea what went on in my house and in my office for them to get their hands on that letter. And I had copies of it in Brooklyn. I had copies of it in Rockland. I hide the copies all over the place. And those creep broke into my house, broke into my office. I'm watching them. They don't know I'm watching them, looking all over the place to get the letter out of there. You can't believe this is going on. And it happened to me, right here in the state of New York. 5 years. Something I knew within a few seconds. Took 5 years. They would not let go until they finally had to put their tail between their leg and walk away and go live where the foolish people are. 5 years of harassment for something I diagnosed in less than a few seconds. Okay? And this lady herself, the patient, wrote a letter exonerating me by telling me she was being treated at Hudson Valley Hospital for polycythemia vera 5 years later. You can't make this up. And this guy, first of all, the pathologist cannot make a diagnosis of polycythemia vera. This was it cannot be done. This is not a pathological diagnosis. It's a hematological diagnosis. And that guy signed a letter and went on his way to Israel for a year, stay there, whatever he was doing over there. Okay? And trying to take my license away for something I didn't know anything about. I had nothing to do with it. I was being set up, I didn't know. I agreed to help the patient, not for money, just to help the patient for the sake of helping the patient. This is what I went through right here in the city of White Plains. Okay? And when we did do when I did do a bone marrow aspiration, they do all kind of stuff to get the hands on the slides of that bone marrow, so it didn't exist. You can't make this up. Now they think I'm stupid. I had 6 slides saved somewhere, they could never find them. And they went crazy after this honest pathologist at White Plain Hospital to try to get him to turn the slide over. He says, no, I won't do it because what you're asking me to do is unethical. Okay? This is happening in the field, in the profession of medicine. This honorable, incredible profession. It happened to me. And happened more than a dozen times. I'm able to tell you about this one because this one is clean. The ugly one I can't tell you about, okay? So therefore then, you have to be careful. And I can tell you, you cannot have essential thrombocythemia with a low ferritin. But you do have zero ferritin when you have polycythemia vera. They look alike, but they're not the same. The symptoms are similar, but they're not the same disease. Okay? So therefore then, you got to be careful. Then when you get to do your chemistry, then that's a different story. You got a whole lot of tests to do in the chemistry profile when you're talking about stroke. There are many, many things you're going to find in that chemistry profile that may be the cause of the stroke or maybe the result of the stroke. Okay, so let's go for it. Take a look at the blood sugar. That will tell you if it's normal or abnormal. If it's abnormal, then the patient probably diabetic. Then diabetes have a high association with stroke. Take a look at the kidney function, namely the creatinine level, the BUN, and the electrolytes. Because if the patient had kidney disease that resulted in renal insufficiency, that can be a predisposition to stroke as well. Okay, so take a look at the serum calcium. Why are you looking at serum calcium? Well, if the calcium is elevated, the patient may be suffering from a disease like multiple myeloma. Because in multiple myeloma, the calcium may be elevated. And then right away, you would order immunoelectrophoresis, protein electrophoresis, Ben-Jones urine and Ben-Jones protein in the urine, and so on and so forth. And do a surrogate again. Okay, you got to do a surrogate because if the patient has hyperviscosity syndrome, the surrogate will go a long way even before you get all this other fancy stuff back. So you can't just do tests. You have to know how to interpret the test. Once you know how to interpret the test, then that can help you. And you take a look at the liver function test. Crucial, because there are many things that can be wrong with the liver that can cause someone to have a stroke. So take a look at the liver function test. Listen, I'm going to stop here. I'll continue to talk more about stroke next week. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.